Good.
I don't have any Wi-Fi.
Although I will say that I know Christine's coming in on, I believe, today, and they have snowstorms. She's had snow.
Oh, that is horrendous. Christine, do you have snow?
I do, and you guys, I am embarrassed. I don't know how to unconnect my headphones from my computer. So I may just have to wear these the whole time like a DJ. And yes, today we have sunshine, but yesterday we had snow, and I've been complaining to everybody. So thank you, Lesley, for listening to me. And I'm going to stay all week next week in Arizona when I get there.
Oh, good. It's great weather here right now.
That's what I hear.
It's really pretty here finally, too, so it's good.
It looks so springy. It looks so springy. I'm so jealous of you all.
Well, we've got a good group, so we'll get started. So just a reminder, to keep your microphone muted until you're ready to speak up. So my name is Matt Martin. I'm the director of the ASU Echo Hub on Behavioral Health Integration. So welcome to session number 4. We're so grateful to have all of you here today, especially on a beautiful Friday. So let's start with introductions. I think I know most of us who are here, but let's start with Adrian Lindsay. If you'll just go ahead and state your name and your institution. Adrian.
Adrian Lindsay, I'm with ASU's Center for Applied Behavioral Health Policy. And I apologize if I wasn't saying hello earlier. I thought I had my mic muted, but I also had all of you muted. So sorry if I missed a hello or two.
No problem. Welcome, Adrian. Let's go to Lesley Manson.
Hi, I'm Lesley Manson. I'm with the College of Health Solutions and the Doctor of Behavioral Health program as well.
Welcome. Thanks, Lesley. Let's go to Eve Teach.
That's actually one of my colleagues, Erin, and I think she sent me a chat that she doesn't have a mic today, but one of our new staff members at the ASU Center for Behavioral Health Policy.
Okay, so that's Erin?
Erin Teach.
Okay, Erin without a voice. Welcome, Erin. Glad to have you here. Let's go to Maria.
Hi, I'm Maria. I'm actually a DBH student, and I live in Florida, and I work right now at Archer Family Healthcare, a rural qualified health center. No, rural health center. You guys making me nervous here. Okay.
It's a certified rural health center. That's funny. Welcome, Maria. We're glad to have you. Let's go to Christine Wiggs. Can you hear us, Christine? You may be muted.
*6 gets you off mute on the phone.
*6.
Can you hear me now?
Yes.
Wonderful. Good afternoon, everyone. Christine Wiggs from Blue Cross Blue Shield of Arizona, and I lead our Applies AZ initiative. And one of the focus areas is mental health.
Wonderful. Welcome, Christine. We're very glad to have you here. Let's go to Kathy next.
Hi, I'm Kathy Hudgens, and I'm also with Arizona State.
Wonderful. Thanks, Kathy. Let's go to Christine.
Hi, I'm Christine. I'm with the Doctor of Behavioral Health program, and I will try to get these switched over by the end of the meeting so I don't look so weird.
I just assume you're having sensory overload. You're protecting yourself. Yeah.
I can't hear all the dogs and the kids barking, so it's good. It is kind of good. For those of you who don't know, I work at home, not with dogs in my office. But.
Welcome, Christine. Let's go to Mike Greenwell.
Hey, I'm Mike Greenwell. I'm with Arizona Children's Association.
Wonderful. Thanks, Mike. Welcome. So here, I introduced myself. I'm Matt Martin here at Arizona State University. And next to me is our new intern. I'll let her introduce herself.
Hi, I'm Mahali.
Hi, my name is Tyler Duddington. I'm a graduate student at the College of Health Solutions here in the Science of Healthcare Delivery program. Just disclosure here, if you guys have any questions or use the chat feature, go ahead and send your messages to the ASU admin co-host account, and then I can address any messages or questions that you have through that.
Then I'm Yash Suri. I'm a grad student here at the Echo team at ASU.
Great. And Tyler and Yash are both graduating next Friday.
Yeah.
So congratulations to them.
Congrats, yay!
Thank you.
Okay. So let me just talk a little bit about ECHO, just as a way of orienting all of us. So ECHO is a model of connecting experts and practitioners together. The purpose is to create a network of knowledge and to make expert knowledge widely available, especially to those who are in need of it. So this is our fourth session. We focus on behavioral health integration, specifically the management strategies that help to make integrated care successful. And today we're going to be hearing from Dr. Lesley Manson as part of our Didactics, and then we'll have a case presentation by Maria. So we're looking forward to both of those. Before I turn the time over to Lesley, one thing that I did want to mention, especially to those of you who are new to the field of integrated care, is about a national organization that you may want to consider joining. So that's the Collaborative Family Healthcare Association. Yash is going to share our screen so you can see the website. So CFHA, the Collaborative Family Healthcare Association, is a national leader in integrated care. They've been around for decades now. And so it's a great organization that you can join and have access to a wonderful and very active email listserv. And the listserv gives you access to a lot of experts across the country. There are also some freebies as well. If you're not sure if you want to become a member, you can always read the blogs and listen to the podcasts. Yash, if you go to that second tab, please. You can do that by going to this website, which is integratedcarenews.com, and you'll have free access to a lot of great information on integration. So full disclosure, I actually blog for CFHA, but I think we've got some good blog posts that we published in the past and some good ones that are coming out in the future. And then I mentioned also the podcasts. We also have some videos that are on there as well. So it's a great organization. You can consider joining, but if you don't want to join, that's okay. You can still have great access to the information they have there. So if you have any questions, feel free to email me, and I'd be happy to talk about the organization. The next conference is coming up for CFHA is coming up this fall in October in the fair city of Denver, Colorado. So that Christine better be attending the conference. No excuses. All right, so I'm going to turn the time over to Lesley, and Lesley's going to do a presentation on management paperwork. So Lesley, time is yours.
Great, thank you, Matt. I'm going to go ahead and transition it over to the PowerPoint. So give me a moment. And I went ahead and used ECHO's background as my PowerPoint background, just for everybody's knowledge there. So Matt had asked me a little while, can everyone hear me first? Is that okay? Okay, great. So Matt had asked me a little while ago to do a brief 15 or so minute presentation on just some of the basics of management paperwork. And but before we jump in, just to kind of give you this, is that we can't identify every single piece because there's a lot. I'm going to go through it in a very specific way, and I'll go through that in just a moment here. But as you work through ECHO, there might be times where we say things like, you know, this is a great way or great place to add in this piece or to have this type of paperwork. So as you go through, you might find yourselves adding additional items or identifying additional things over the time. So these are just some of the main areas. And as I started thinking about, well, how would I start to put them all in play and consider what is a brief, presentation on management paperwork and integrated care? Because that can be piles of different things we can come up with. I really started to put it into these areas. One is legal and professional. Another is quality improvement, quality assurance, which is different, service lines, billing, coding, and compliance as the last one. Some of these intermesh with each other, and as I present, you'll notice that as well. But before I begin, I wanted to first give you this layout and say this is how I'll do the presentation, and ask, does anybody have any questions in any of these areas off the top right now? Because it perhaps is something I could address during the presentation, or it's something that we could address after. So does anybody have any questions right now? No, we love you. We're so excited. Oh, okay.
If you have any questions, you can send chats to us, or you could just unmute yourself and ask Lesley directly.
Yeah, I'll try to keep with 15 minutes. Feel free to ding me, Matt, when I'm getting close. I know many of you probably know me or have seen me, and I, can get on my, horse or stand on my block for a little bit and talk. So I'll just try to keep it succinct and very direct for everybody. So let's go ahead and open this up and start really focusing on the legal and professional lens. So as I consider legal and professional paperwork for management, I really want to first start with a piece of thinking about confidentiality concerns, consents, considering agreements in businesses. And so that's some of the first things that are going to come up. So one thing is, as you start to work with integrated care, you want to always, whether it's you're building the plane while flying it, you're going to go back and check your paperwork, or you're really starting to look at developing a new practice. What you want to do is look at your notice of privacy practices. This is what's going to actually define your services, define sharing of information, and identifies other agreements. This is something that the patient receives typically yearly. I'm sure you all get it and kind of get annoyed. Every year I get this notice of privacy practices and my HIPAA statement. I'm like, yeah, I have 15 million. I just rewrote my last one for my organization. You can keep it. But it's very important to be reviewing that and review it through the lens of integrated care. That's one of your first steps related to really building a firm as far as management and integrated care practices. So this is where you're going to actually write in the notice that you are sharing and define the sharing of that information. You're going to talk a little bit about the different types of providers that you have employed, and you're going to include them as one of the provider types, or perhaps you make it more general as far as individuals who are licensed or clinicians or providers of all kinds. This is also something that in order to change, many types of management or healthcare associations may need to get in touch with their legal team in order to update it. Many do not need it as well. It's about 50-50. It just depends on how large of a practice you are or how kind of safety oriented that your practice may be. So there's very specific ways to actually update the notice of privacy practices. I actually have many examples, and I've helped large-scale ACOs throughout the U.S. as well as FQHCs and other smaller practices update their notice of privacy practices. So if folks are interested in a sample, I always can talk or share that at another time, or post it somewhere for you all to see. But it sets that stage for information sharing and provides the kind of clearance that this is one of the forms that you've done and you've attempted to provide that information to the patient. Okay? In addition, what you need to do is you need to update any agreements, and you need to have formal agreements. Those are BAAs and QSOAs, and I'm going to go into those in a moment as well. You also need to look at any other agreements or confidentiality or consent documents you may already have. These may be for building other community connections, and maybe for national type of programs or other types of things, state-run types of organizations that you might end up wanting to build or have a relationship with. Those agreements are really essential in management, and to be able to build something that has legal foundations and ensures that you share and keep your confidentiality of your patients, but also request the required information of that other entity of what you need from them in order to operate with integrated care in mind. Okay? So now let's take a look at the BAAs and QSOAs. These agreements are very specific. So most healthcare organizations are extremely familiar with BAAs. This is kind of like the standard old hat practice that in healthcare we've all done for many, many, many years. And then about 10 or 15 years, maybe a little bit more now, but about that, so many years ago, we ended up starting to use QSOAs instead. And in specific, there's two different reasons why we do this. And sometimes you'll have a hybrid of both. Okay, within the organization. So a business associates agreement is typically for any third-party organizations. So a healthcare organization, just to review, is the first party. Your patient is always the second party in all of this, and that's why they call them third-party. Third-party organizations are any organization outside of the healthcare organization you work with. Okay, so that's why that's deemed third party, just for that knowledge. And so that's an agreement where you have with someone who's doing any type of general healthcare services with you. So that's just general healthcare services of some kind. You may have those agreements where you'll have certain providers come to work with you. Perhaps it's a referral system to another organization, etc. All of these things you want to update related to integrated care. If you're doing a QSOAs, those are mandated and required for anyone that's receiving federal funding. So this is extremely important to know and to obviously review and update. It's also required when you're providing substance abuse treatment, and it's required for all individuals that are governed by 42 CFR Part 2. So if you are a qualified organization under 42 CFR Part 2, and you receive any federal funding, you're going to be doing a QSOA. And with that, you also might have a hybrid and also have a business associates agreement as well. And let's go through a little bit about these different agreements and what they include so that you know. And hopefully as I go through this, you can start considering integrated care as some of the items that you need to really address in here. So a business associates agreement is going to talk about what's permitted and required uses and disclosures of fee, okay, so patient and health information. It outlines the requirements related to not using or further disclosing information prohibited by the business associates or related to law. It safeguards all the use. It also recommends any best practices that may be recommended, oftentimes by legal counsel, so by your lawyers. And there's also a disclaimer of agency relationships. So typically people will say, this isn't to profitize this other organization. This is about patient care and delivery. There's also information or requirements about media requirements, how you may discuss and disclose this relationship, or how they will, how things are going to be listed on flyers. And specifically, these agreements need to be updated related to integrated care. What type of information will this individual bring back to you? Perhaps it's an organization that you're working with to deliver your behavioral health care at your physical healthcare office, or vice versa, in which case you'll have this agreement and you're going to note that they require to have documentation sent over, you're going to have a shared medical record, et cetera, et cetera. Your flyers are going to have both your symbols or one, or yada, yada. So this is all really important as you consider integrated care, to go through all of these documents that you have legally, okay? Next is your QSOA, your Qualified Service Organization Agreement. And remember, this is those that are bound by Part 2, confidentiality regulations, and have received federal funding. So as you look at this, one of the biggest things is you have to acknowledge the Part 2 regulations. You have an agreement to decline entering into any judicial proceedings or efforts to obtain unauthorized access to patient information related to substance use. So basically, you both agree to the other components of why CFR Part 2 was actually, constructed. And you also may wish to include all of those previous things in the BAA as well. Sometimes people have both in place, and sometimes they just include it in this one. But these are the two areas. And of course, as you look through this, you'd also want to consider that integrated care piece in here. What is that going to look like? What is the information going to look like? How would you define it clearly on here? All of these aspects need to be included, right? Including how does a patient obtain that information or obtain access, etc. Okay, so these are the first parts of that, starting to look at the legal and professional lens for integrated care and development. You also need to start to look at, for legal and professional lens, is organizational alignment, mission, and chart incorporating integration. So what I mean by that is, too many times integrated care facilities, or facilities in general, will actually build on and bring on integrated care, and they'll build that plane while flying it, but also they'll forget we need to actually look at our organizational chart. We need to start looking at, who do we have in place that's at the top of our organization that's supporting integrated care to move forward? Is it that we just assigned the medical director as part of that, or just assigned the behavioral health director, but we never actually stepped them up to be the integrated care director, or given them even further power or influence to be able to make change in the organization? If you're really wanting to move toward integrated care practices, whoever's going to be starting to look at this needs to look at integrated care as far as, how does it align with our mission as our healthcare site? How is our mission built in with integrated care in mind? And if it's not, maybe we need to look at updating our mission statement for our organization. Maybe we need to look at inviting whoever it is that has this task or this vision of integrated care to our seats related to our executive office and our executive team. They need to be sitting here with us, because integrated care is about all the lens of healthcare. And we need to be collaborating together at the top, not just this one piece down here. So that's really important as well. We want to go back and look at that organizational alignment and ensure that we're starting to consider this and plan for this in the future. Okay? We also want to look at how are we going to design trainings for your sites, your staff, what are scripts and signs going to look like, and how do we incorporate our security officer and ensure that annual trainings are provided with all the legal and professional concerns that are needed to be addressed. So we also want to do that. And I say the scripts and signs because I'm a true believer, and if you've heard me speak, I talk a lot about transparency in healthcare. And so with scripts and signs, I really believe that everything that we do and we want to communicate verbally to a patient, we should have a sign right up there that shows and describes those services. Maybe it's in pictures, maybe it's in choice words, but really we need to have that. So if we're building integrated care, let's have a sign about integrated care with all of those faces of their healthcare team, with their names on them, or perhaps with job titles. Start to influence folks to understand what this means and how they have a role in this, that their face is up there too. Patients are part of integrated care and they're part of their own healthcare team. So scripts for that, everyone on the healthcare team can say the same thing. And so you see that alignment and you see that confidence within their healthcare system about what it really means to deliver integrated care and how it really impacts our community and our patients, okay? So as we move forward, we're going to start to look at quality improvement. I know my time is ticking. It's been 10 minutes. As we look at quality improvement and think about paperwork, what I always say is when we're starting to look at this, whether you're going to, again, start at the beginning or look backwards, I want to say, what do you already have as your list of PDSA targets? What are you doing to enhance quality improvement with the integrated care lens? What's already on the table? Let's look at it. Let's take that list and let's review it through integrated care. You've got to be looking at that list every year, and you've got to get on the teams for quality improvement to ensure that integrated care and that lens is taken in consideration. You also need to your analytics, okay? You need to look at all of your personnel related and integration. You need to look at population health management. What do we already have in play? What are we doing? And how is integrated care starting to be a practice in that? What do we have as far as service lines and how have we developed those? And then what are our targeted metrics just for integrated care and all of the rest? So when we think about quality improvement, we're already addressing things like NQF, CMS considerations, right? MSSP. So I'm looking at Medicare shared savings plans, national equality forums. We're going to look at the National Center for Quality Improvement. We're going to look at all of these different types of organizations that we report to, UDS, Universal Data Systems, that as healthcare entities, we are required to report certain metrics every year, and we choose certain metrics to do that. We want to sit down at that and look at that, what we've chosen as a healthcare entity, and address it through the lens of integrated care. And I challenge you all, if you don't know what yours are, to ask and start looking at it through the lens of integrated care. Perhaps there's changes this year, or perhaps you just get on it for next year. Either way, it's going to make great stride with further inclusion into the healthcare system. So as we move forward to quality insurance, so quality improvement is looking forward, okay? And how do we improve our quality and make greater changes? Quality assurance, I always say, is looking backwards. It's an easy way to say it. It's finding the problems. It's like, I'm going to look for you, okay? It's finding those problems that are there, okay? And that's quality assurance. So that's where we're going to look at things like auditing charts. We want to start to create those pieces. We want to know what our code and compliance regulations are for quality assurance. We need to develop those with an integrated care in mind. We need to develop our targeted metrics looking back. So now we're going to not only develop them for the future, okay? We want to look back and say, what did we do? And how well have we been doing it? And when I look at it, do I find that perhaps if I viewed it through the lens of integrated care and added other team members or changed roles and responsibilities in some way because of an integrated care team, could I have improved those targeted metrics? Okay. I'm going to look at the service lines and outcomes, trying to find problems again. I'm going to look at our analytics and ensure that if now I'm looking back, I want to be able to figure out what I need to look at, or quality improvement. I need to request that they add these things on so I can look at them in the future. And of course, with personnel, this is the time where you're looking at personnel not to identify trainings so that they can continue with integrated care in the future, quality improvement. Now I'm going to look back and say, when I'm thinking about integrated care, how are their job expectations and requirements aligning with that? This is something that often is not always done. And if it's done, they write a new job description and leave it as that. We're hiring these integrated care folks, or now all of you mental health folks are now integrated care. Let's really look at those key performance indicators. Who has shown us before that they have those qualities? They display those roles and responsibilities prior. Let's look at it so that we can really identify that. Also, if we're doing it, let's look at the medical providers, the nurses, the other medical assistants. We need to look at everyone, because in actuality, what we want to do is enhance and change all those job descriptions to make it a requirement that here at our facility, we are an integrated care facility. And if you're working as a primary care provider, a primary specialist, a psychiatrist, a behavioral health provider, a nurse, whoever it may be, you work as part of a member of a care team. We work together with the patient with us on that care team. And that's a job responsibility and role that's expected of you. And it's on your job list, your description. We've got it right here on there. And every year we're going to review you as that. And I'm going to ask you, will you accept that? That needs to be part of those initial pieces of management, looking back at paperwork and really developing. We need to look at key performance indicators and review all of those reviews and evaluations of the past to identify, are they going to be a good candidate? Or what do I need to look at? Or what are red flags for the future? Okay. Then next is service lines. What service lines do we already have in place? Okay. What are we doing to provide care? Do we have diabetic educators? Do we have nurses that are having certain types of roles? Care management, case management, etc. Okay. What do we have going on? SBIRT, generalized counseling or behavioral health services. What do we have? And really looking at it through that lens of integrated care. And once you look at it, what types of workflows do we have in place for that? As we look at workflows or swim lanes a diagram of a workflow. When I look at either of those, how do I see it in the lens of a care team, a full care team? And is that something when I think about integrated care can make a change or impact here for a benefit? Can I improve the efficiency or the effectiveness of the service line by embedding that or changing it in some way? We want to look at that. We want to identify champions that are in place in each of those service lines that accept integrated care and love it. They're going to speak to it. They're going to want it. So we're going to start to look at those timelines and really build up those champions. We need it in management, providers, and staff levels, all levels. In healthcare, you can never forget the staff. They are your predominant employee. Your providers are the ones who make the most money and cost you the most, right? But staff are your predominant employee. Those are who you have more of. They actually know your patients more so at times than any provider can. I have to say that even in my own clinics, the staff knows them like the back of their hand. They've grown up with them, they live next door to them, and they do things with them. I may not at all. So there's a distinct difference. So the staff need to really be educated and know about what integrated care means and knows where we're going with that. So they have that formal script so they can be champions too of this and communicate to our patients about it. It's amazing when the front desk actually help to move a patient into an integrated care team and help them to be more a part of their care and use behavioral health or other things. And that's coming from the front desk, not the provider. We want to look at population health and registries as part of your service lines and consider again, what changes do we need to make with integrated care in mind? We need to look at fidelity, model fidelity of our service lines. What does that look like currently? What is it going to look like with integrated care? We need to look at outcome measurements, metrics, and analytics, which should already be developed for your service lines. And if not, you got to build that plane right now, right? And through that lens of integrated care. Okay. Last, but definitely not least, and this is always my bag, right, is billing, coding, and compliance. Okay. Super fun. Everybody's so excited about this one. So with billing, coding, and compliance, what we want to do is first we want to look at empanelment. That's a lot of paperwork. Your HR team should know about that. That's making sure that all of your providers have an existing NPI number or National Provider Index number or have applied for it. And you can't work in healthcare without it. So they need to make sure that they have that. It's up to date. It's good. And then they need to work on all the empanelment for any insurances that they want to do. And they might want to pick and choose. Some organizations just say, I'm ripping the thing, and anyone the medical providers are empaneled with, specialists, we're all empaneled the same. But many organizations actually say, we're going to only empanel with a few of them. And then what we need to do is develop our sliding scale related to this service and have that available for everyone. So if you're not choosing to use your insurance to see our integrated care team, or we don't cover that insurance, then what you need to do is recommend that they go on sliding scale or provide referrals, right? So you have to have that all developed in the front end, right? As well as scripts for your front desk of how to check insurances to ensure that they have the ability to actually see someone and what those requirements are and be able to have knowledge of those sliding scales. And just a reminder, there's something called the Federal Anti-Inducement Act, which is basically about in healthcare saying you got to charge everyone the same and you've got to follow the rules on that. So there's no such thing, although healthcare places do it all the time, there's really no such thing as things like, we're not going to charge a copay, or because you're this patient, you don't have to pay. Actually, technically, we charge everyone's copay, and everyone's required to pay, and everyone has that unless you're a free clinic for everyone, okay? So everyone has to be treated the same when it comes to payments and all of that. However, people can use sliding scale, but everyone has the option for sliding scale, because you can walk into any healthcare agency that takes your insurance and say, I'm not using my healthcare insurance today. I'd like to go on sliding scale. That's an option legally for everyone. Next, okay, if you have patients who struggle to pay or can't afford, or they do that warm handoff, and to pay that $40 copay for the warm handoff just is something that they can't do, okay? They're a Medicare patient, elderly, fixed income. So you don't say you don't have to, we're going to waive your copay. It's not that. In the back end, up front, in all of this paperwork, what you do is you design a system that says, what we have is for patients who have challenges, however you might want to term that, we go ahead and wipe off or discount so much money. So that system is in play. And so you want to develop that as well, because that can always happen. You can discount the $40. You just cannot say we don't require a copay. Makes sense, everyone? Hopefully people are getting it. But all of this needs to be built in the front end. If not, you're actually under default and perhaps even some ramifications from your insurance companies, etc. The likelihood of anybody catching it is fairly low, but it's important that people know what is appropriate in the billing, coding, compliance, and legal realm of this area. Next, what we want to do is do the 5 steps review. For those of you who know, I've come up with the 5 steps about, 15, 20 years ago now. It's been republished I think like 10 or more times now and published in a few different books. And basically that's a way to go through very specific steps to ensure that the integrated care team is actually able to bill and be built into your healthcare system to meet coding and compliance and training requirements. So I always recommend that's something to go through and make sure that folks are up to date on that. Next, it's to create documentation templates. That's to ensure that any documentation you're doing is to meet billing and coding and compliance standards. Many folks have learned in their, kind of degree and licensure how to practice, but they don't always learn the requirements to document for billing, which is very different than practice. So the billing documentation requirements are very different, and some organizations have extra things that they build in. It's in the contracts you receive that are about 200 pages, so it's kind of ridiculous, but it is important to identify those. I do have documentation templates for that. I used to be an auditor and coder, Medicare for a small stint. And so I do assist places with identifying and building that so they're under compliance. These are things that are really important to reach out to folks and be able to build and put in place prior to people operating. Because one quick look can bring you back and knock you back. So you can end up having fees or other things you need to pay back. Okay? Next, you want to look at all of your metrics and make sure that that's embedded in any of your documentation and compliance there, and including social determinants of health, because that's always going to get you more money long-term for value-based contracts as well. And you want to look at that any data analytics are being able to be pulled from any of your documentation and coding and billing that you might do. Because in integrated care, there's a lot of great demographics and data you can pull just from billing, coding, and compliance pieces. These are all the great structure things, as well as making sure you build your performance, your return on investment designs, and ensure that you've built your auditing forms. Whenever I do coding and compliance for any type of billing code, we also create an auditing form so your peers can review your notes about once every 6 months, so 2 times a year. And they'll go through a review of that. And then they can provide feedback. That's really helpful. It helps us to, as providers, to be able to kind of be knowledgeable about what to look for in a different way and to do that for someone else. And that's usually something that, is de-identified, so you might not know who you're reviewing as far as the documentation, but it's very helpful to design that in the beginning as well. Okay, so these are all a few things to really consider when you start to think about the management piece. So going back to my original post, here's those framework for thinking about management paperwork. So I want to just check in. Any questions from folks? And I think I did my 20 minutes.
I have one, Lesley. I have a couple actually, but I'll just throw one out there and see if others have some questions. Around privacy and confidentiality and 42 CFR Part 2 and all that good stuff. Mm-hmm. Have you come across any really good resources that are like a, one-page fact sheet, really simple, really user-friendly? I've seen a lot of guides and things that are kind of overly complicated, and we work a lot with different organizations that have a lot of paraprofessionals, and I just still find with a lot of our community partners, there's so much confusion around what they can and can't share, and almost the idea of even having a release of information and starting to talk to each other is like really novel. And so I'm just wondering, like, a good resource to share with people, if that's maybe something that could be posted after the meeting or something.
Yeah, so I'll be frank, and for those of you who know me, I'm pretty frank and transparent with things. I would say, I like what you say, there's a lot of confusion. I think overarchingly, it's more fear. And, you know, in organizations, sometimes they're risk aversive, and that's the choice of the organization. And so it always comes back to that. No matter how much education or how much clarity you can provide, they continue and probably will be fear-based for a large period of time. And so definitely, I think that there's one document that I enjoy. It's 3 pages though, but it gives what it does. It's actually from SAMHSA, HRSA, and so in their integrated care section, and it's all on 42 CFR. But what it does is it breaks it down as far as examples. And I'm not sure if you've seen it, but I love it. So it's like Mark, it literally is like, and it has a little diagram, and it's like Mark is a provider at a FQHC, and he's starting to prescribe Suboxone for opioid, considerations, but he's also a primary care provider. He also has a behavioral health provider that he works with these patients to ensure that they continue on a pain management treatment, right? And you'll have a little picture of like the organization and 2 people. What do we need to do? And it says like, 1, you need to have X, Y, and Z. You are not qualified under 42 CFR. And then it'll be like, next one. Mark is working as the primary care and the opioid prescriber, and they do groups with this person over here who's this, and do this. And then it'll be like, yes, now you actually need it within your organization. And that information, even though they're the same provider working for the same organization, can't share it with any other primary care providers without doing X, Y, and Z. And then it'll be like, the next one is an integrated facility who does X, Y, and Z. So it's nice. I mean, it is 3 pages because of all the examples and how they lay it out.
That sounds absolutely perfect. Something.
Yeah. It's much easier to understand than reading the articles and the pages, even when it comes from CMS or SAMHSA and HRSA and all this. When you read it, sometimes you're like, well, what if it's this? So I like that document because of that piece alone. So I will say that, but overarchingly, it still takes time for people to kind of put their toes in the water and allow it. And what I always say to people is that's fine. It's okay to be risk aversive. What can we do if we work within risk aversive? So you can still move forward. Let's just get the release done. You can do this. Let's just go and put this here. And it's just making more steps in the meantime. But if you want to move forward, sometimes we need to kind of look backwards at some of those traditional steps just to be able to move forward. And then over time, then they can open that up. And I also find having them have outlets with large-scale, multi-billion-dollar ACOs is also helpful. So often I'll say, hey, would you like to see the practices of these clinics that they allow me to share their information? I built it for them. This is what they do. So their names are all over it, and those practices have allowed me to share it. And I say, here you go. And when they see that an organization that's much larger, much stronger than them have done it, they say, okay, now we'll go. So I find those things as helpful sometimes for folks. And again, there's a lot of fear. Sometimes it's misinformation. But I think at this stage, there's so much information that it's still just, it's just a concern. We've been taught things that weren't even accurate, even as psych providers. So if I think back, right, I'm a traditionally trained clinical psychologist. So 20 years ago, I was trained that nobody, I could protect my notes and nobody got legal access to them. And I didn't have to give access to anyone, even my patients, if I felt like they would be hurt by that. There's actually no legal standing that says that I can do that. In fact, every single court of law in the United States has not supported that for us. So that there is no standing of that, but we were taught that. No, that's our ethics. That is not the law. Our law actually says the patient owns our documents. We're holding it for them. The moment they request them is the moment we should be looking at that. We have so many hours to do it. We can didact or protect if we feel that there's misunderstanding of that information, but we have to offer that to the patient and say, I'm going to didact the notes and protect that for you. The patient can say, nope, I want it, and then go to the courts and get it. They have every legal obligation unless they have in the past hurt themselves or hurt someone else by reading that documentation. If that standard has been there, that's the only time the courts have upheld that. So, or stalk someone. So there's specific elements that have happened. So it's important for us to like be realistic. We've been taught things that aren't real, right? But we hold on to it, you know? So I think it's important to always just be very frank too about it. Like, okay, then what can we work with that? If you want to remain risk aversive, I'll support that. But let's look at then what we can do so we can continue to move this forward, and let's re-look at it again next year, you know? That's a stance I take. Maybe other people take different stances.
Thank you.
Okay. Any other questions? Okay. Well, hopefully that it helps people to kind of have a preset of different things to consider for management, or to look back and ensure that those are things that have been looked at with the lens of integrated care. So Matt, I turn it over to you. Uh-oh, can people hear me?
No, I can hear you, Lesley, but I can't hear Matt.
Oh,
Yeah.
okay. Matt, do you need me to do anything to stop share or anything? I don't think they.
Oh,
They're fixing it.
Command Central's on it.
Right.
We got this.
Hey, Lesley, can I ask one more question?
Yeah, go for it.
Kind of baby stuff, IT stuff.
Mm-hmm.
Around the fidelity piece,
Mm-hmm.
how do you persuade clinics or health systems to invest in, measuring fidelity to EBPs? Because I find, we partner with so many groups in the community, and they say they want to use Espert or they want to use motivational interviewing, but it's always sort of a, well, can you come in and do that for 2 hours? And then we don't really measure anything.
Because we know they learn motivational interviewing in 2 hours. Yeah.
We don't really want to, pay to measure anything or see if people can actually do it.
Mm-hmm.
And so how have you kind of managed that historically? I mean, how do you make, I don't know.
One is just through naturally developing relationships over time, and the more they know me, eventually they reach out. Most of the places I consult with, even if it's been one phone call in like 6 months, or 5 years ago, they'll call me back and say, hey, I want this now, or I'm ready. So sometimes it's using motivational interviewing to let them know when they're ready, they'll come back. But another step is I always strategically align it with their national reporting metrics, any guidelines, mandates, state mandates, funding. I align it with what is important for management to hear and to know. So that's how I always discuss it. So that certainly I'm more than happy to do this. And I also want to for you to pay attention to the fact that if we do it in this way, it's going to align with this, this, and this. And we can actually begin to see whether or not it's actually making an influence and a change long-term for patient outcomes, for your provider satisfaction, for building the team, whatever it might be. And I link it to money every time. So everybody knows anything, I link to money. So not in my personal life, but when it comes to healthcare, right? And that's essential because that's what they want to hear. We need to sustain it and we need to build it. And when they think about using you, they're thinking about spending. So if they're spending, they need to see that ROI is coming back to them. And sometimes I might even, if they're on the edge, I'll even say, hey, if you'd like, I'm more than happy to draw up a sketch. It'll probably take me about a half hour, and I'll actually draw up a return on investment metric for you based off of your, value-based, options or your metrics or what you're receiving currently for funding with X, Y, and Z, and how it may improve that. And so they might have to give me some data so that I can do that. But sometimes I'll actually do that too. And that speaks a lot. When I show them money, like literally people are like, why was she not here last? And so that speaks a lot to it too. But
well, that makes a lot of sense because I know you obviously don't see the return a lot of times when the fidelity isn't high enough. So yeah, okay.
This is Kathy. I've just got one thing to say about that too. One thing that when we do evidence-based practice training, we always link it to outcomes, and the health outcomes are higher if you can show them, and especially if you can get your nursing staff involved here, because EBPs are really important in their training. So they're always thinking in that lens. But that's a really good advocacy team member to get into that, but also put that into your health outcomes using the evidence-based practices that you get the most for what you are looking for that population. And it also identifies gaps in CEUs. So if that aspect of provider expertise is missing, then they can identify that as maybe a pathway for a CEU.
Yeah, that's another great thing. And now medical providers are required to do other CEs related to, improving quality, and they're always tied to evidence-based. And if you don't know, the medical requirements actually tie to evidence-based practices, in which case they're actually supposed to be evaluated every year related to that. They only have to evaluate them on a few of them every year, but it's important you can actually align with those markers and say, and by the way, this aligns with the requirements from the AMA related to licensing and meets this metric and how they're now operating. So that's always nice too.
Thanks for that great discussion. So can you guys hear us? All right. So we've got about 13 minutes left, and we have to make a decision because Maria has a wonderful case to share, and I want to make sure that she is able to tell the full story of her site, her clinic, and the improvement project that she is leading. And I also want to make sure that we give her enough time to receive feedback. So let me pitch this idea to the group. What we could do is we could ask Maria to come back so we can give her her due diligence on this case presentation, or we could start it today and then finish it up at our next meeting. Let me start with Maria first. Do you have a preference? Do you want to hold off until our next meeting in 2 weeks, or do you want to start?
I think I want to start.
Okay.
Okay,
great.
Maria, you have that. You're speaking about your project, right?
Yes.
Yeah,
yes.
It's a good one, and I think it's good to start it. Yeah.
Thank you.
Okay, great. So let's start it. And just a reminder, the case presentation is an opportunity for us to learn about what someone is doing on site at a clinic, and their effort to address some kind of a challenge or barrier that is getting in the way of improving the clinical service there. So once Maria does her presentation, we'll have some time, maybe today or next time that we meet, to give some feedback. So Maria, I'll turn the time over to you to do your presentation.
Okay, let me share the PowerPoint. Oops, I'm clicking share. There we go. Something happened. Looks like it's sharing.
Yeah, we can see it working.
Okay. Okay, so obviously that's the ECHO framework, the PowerPoint thing there. Let me go back here because it's not letting me. There we go. So my question for my peers is how to increase the behavioral health referrals in a federally qualified health center, which I was doing my CP2 project in North Central Florida. Our target or our ideal state was to improve screening identification referrals to behavioral health from 4.6% to 10% and increasing same-day access in the clinic. Our current state was that and this data is not the most recent one, this was the one that I collected when I was doing this PowerPoint. Patients seen by the PCPs was 4,093. We had 3 adult providers in the clinic, 2 pediatric providers, 30 internal medicine residents, and 1 behavioral provider, which is an LCSW. However, the total referral of patients to off-site behavioral health services and on-site was 128 patients. The measures that we were looking at was depression, and for patients age 12 and over who were screened with depression with a standardized tool, the standardized tool was the PHQ-2, PHQ-9. The second standard is if they had a follow-up documented, if the the screening for the PHQ was positive. The system, eClinicalWorks, determines positive if the PHQ is higher than 10. Screened and had a positive screening were 2,038 patients. Appropriate follow-up was 646 patients, which was a 31%. However, one of the things that the COO clarified with the follow-up is that if eClinicalWorks saw that the patient had a PHQ-2 and then a PHQ-9, that would be considered as a follow-up. And it didn't even need to have an intervention plan. So that's something that happens in their system. What other things with our current state? So I did a workflow analysis in the clinic, and obviously this doesn't look like lean, but I wanted to make it simple for this presentation. And this is only the days that, this is a post workflow. This is the day that the behavioral health consultant is in the clinic. A patient signs in, it takes them about 3 minutes, then the patient is actually checked in. They sign in on a notebook, then they go sit, then they're called back and they check them in the system. The patient waits. There's a small TV there, which they're seeing some educational health videos through TED Talks. And that takes about, it took the patient a wait time about 12 minutes before the BHC came and got that patient. But if you see at the time that the BHC is spending with the patient, that is outrageous for a center where we want to just do brief interventions. For the first patient, she stayed there 72 minutes, and the second patient, it was 41 minutes. During this time as well, we identified other barriers, which we'll continue talking about. What were the recent changes we created in the clinic? First of all, the clinic never had a BHC there. They never had a behavioral health provider. Well, they had a behavioral health provider about 4 years ago, but that was doing long-term care and that didn't work and they stopped doing that. So now they received a grant from HRSA, the SUD and mental health grant, and they were going to start integrated care, but it was specific to brief interventions with a focus on substance abuse. So the recent changes was they integrated a BHC into their system. February 25th was our 5th day. There was training provided to the primary care providers. There was training provided to the support staff. We created a new workflow for the primary care providers, which they saw during that training. We created a workflow video, thanks to Dr. Martin that gave me that suggestion because I didn't know what else to do. We moved the BHC closer to the primary care team because she was in completely a different office closer to the peds, but she was not accessing the adult providers with some issues there. So we moved her closer, but she still has her door half closed, so I can't increase referrals if that happens. And we created new policies and procedures for the behavioral health program, which are currently in the hands of the board to be approved. Another thing that we did, and it's not there, but I talked to the person that does orientation and I asked her for sustainability and to continue the program to include the behavioral health director, which is also the BHC, into the orientation process so that way every new employee that comes in understands the process and knows that it's an integrated care site. The barriers that we found to change is that the BHC pulls patients to her office from the exam room. I believe that's why she's taking so long with them. The BHC travels between clinics for some patients and chooses not to use the telehealth equipment. The BHC timing with the patients, and there's 2 providers in the clinic that will not refer to behavioral health services. There's one that sees about approximately 17 to 21 patients at noon. That's her number. And when I asked her about referring, she said that she's too fast. And the second one has been there, but she's not referring. Dr. Ramasco is not referring. So I looked at the time that she was having with all of the patients to help the management team understand that it's creating a big barrier because if she spends this time, I'm going to have left referrals in the clinic. So 40 or more percent, if for 40 or more minutes, 50% of her visits are 40 minutes or more. 47% of her visits are 30 minutes or more. And 30 minutes or more was 31 minutes or more. and only 3% were actually 15 brief interventions that she did. And really that was just her going and saying her name and coming out of the office. What questions do you have for me?
Thank you, Maria. Let me just summarize to make sure that we're all on the same page. So it sounds like your main question is about how to increase referrals from about 4% to 10%. There's been a lot of great activity at your site. You hired a BHC. There's been training of providers and staff, the development of new workflow, and the creation of new policies. It sounds like there's some concerns about the amount of time that the BHC is spending with patients, and that seems to be a barrier, maybe not only in how the BHC is perceived by the rest of the clinic, but also a barrier in terms of the number of patients that the BHC can see. So if that is a good summary, we can move to clarifying questions from the rest of the group.
That's a perfect summary.
I have a question. What kind of training did she have? Because if she is only doing 3%, what she would call brief interventions, did she have brief intervention training, or was she just trained on the basic practice flow?
When the BHC was hired, and this is probably too much of a story, but the BHC, I was in a different center in that clinic, and that BHC that they hired now was actually my supervisor. She reported having experience with doing the brief interventions model in other clinics that she worked on in the past. But now that she's doing it, it's not what I expected.
So from my thoughts, it sounds like more of a training and workforce issue, because everything else sounds as if everyone is open to changing the workflow, open to the process. But then I would ask again about the other people and how their understanding is of the model. But her in particular is, to me, a sort of a center point.
So continuously every Wednesday that I was going to the clinic, every Wednesday I would sit with her and talk to her about the brief interventions model. I actually provided her the videos that I've done in brief interventions during the courses. I've worked with her very closely to get her to a point where she was documenting her accurate time, created her templates for the system, done everything that I've been trained to do through the DBH program, but it doesn't seem to be working to a point where we have telehealth equipment. There was telehealth equipment, and patient is there waiting for her, but she decides to get in a car and drive to a different clinic to see the patient instead of staying there and seeing them through telehealth to help with that, improve the process. And that was the day that I was actually looking at the post workflow, but she decided to get in the car and move. So I don't know what else to do at this point to improve. The CEO, which was my management preceptor, and quality and risk were working with me, and they were the ones that suggested that I calculate specifically how much time she was spending to show it to her. We did that, but it has not improved anything. However, they are hiring a second behavioral health consultant because they have money left over in the grant. And my concern is that she's going to be the one training them.
So Maria, your concerns sound definitely legitimate, and we will have to leave it at that and come back at another time to ask more questions and to provide some more feedback. Maria, can you join us in 2 weeks?
Yep, I've asked permission here at my job, and they have blocked my schedule every 2 weeks to join you every 2 weeks.
Okay, wonderful. We will have you join us again in 2 weeks. At that time, we'll just do a summary of the case, and we'll pick right back up where we left off. I just want to thank everyone for coming today. Thank you for Maria presenting that case. The next time that we're going to meet is Friday, May 17th from 12 to 1. After the meeting today, you'll get an email with a link to a survey. And so if you will please complete that survey. I think that's it for announcements. So please tell anyone that you think might be interested in joining our group about ASU Echo. We'd love to have them join us. And if you have any questions, please email me or one of our support staff here. Thank you so much, everyone. Have a great weekend.
Thanks. Bye, everyone.
Bye-bye.
Thank you.
Okay, so that must have ran out of juice.
Yeah. Did everyone already send their contact information?
We have them all.
Oh, perfect.
Yeah.
Yes. Hunky. He like joined 20 minutes later.
I know. So
yeah, we probably will do it because they're not going to be on campus anymore. You don't have any other reasons to be on campus right now, so we'll do Zoom, and we'll just send you the link, and then you just join through your browser.
So Elizabeth Wilson. Okay.
So what do you think?
Oh, that's cool. I like Maria's presentation. It sounds like she's like having some problems. I wonder why that lady isn't making any effort.
I did
It's kind of weird,
too.
huh?
It's not too uncommon. It sounds like that.
I replied with that. Yeah, I replied like 4 minutes.
So like if I were to go see that psychologist in private practice,
No, I saw.
the session would
I
be
just
an
forgot
hour
to do
long,
reply
60
reply
minutes.
all. But
And it's really hard for a
I
psychologist to
did
go from private practice to working in a very busy primary care clinic where the visits are 15 minutes, 20 minutes long. It's a learning curve.
They said that they
So why is that
were.
offered then? Because it doesn't seem like you can really,
They went to,
you know, get an idea of the patient in like 15 minutes or 30 minutes. Can you?